Ladies and gentlemen, to today's tutorial. Today we are beginning our journey with the postpharyngeal guts, the alimentary canal below the pharynx. Remember that we are going to begin with the Osufacus. We run all the way through the anal canal. So today we want to look at the anatomy of the Osufacus. Remember that the Oesophagus is a fibromuscular tube. Actually, as we've said, extending all the way from where we call the laryngopharynx all the way to the Oesophagus. In other words, it's going to help transmit food from the laryngopharynx into the stomach. Now, this tube is about 25 centimeters long. It's going to start all the way in the leg region, come into the thorax, and then enter the abdomen where it meets the stomach. So, without further ado, let's begin our journey looking at the anatomy of the Oesophagus. So now you realize that over here we have the pharynx over here, and over here we are going to have, behind the larynx, we are going to have the laryngopharynx. And laryngopharynx at the lower border of the cricoid cartilage. This is the cricoid, this is the thyroid cartilage, this is the anterior lamina, posterior lamina of the cricoid cartilage, lower border of the cricoid cartilage, or at the level of C6 vertebra. There's C1, C2, C3, C4, C5, C6. The lower border of the body of the C6 vertebra, we are going to have the transition from laryngopharynx to Oesophagus, this fibromuscular tube. Now, what we find is that, yes, at this level, therefore there will be a junction, which we'll call it pharyngo-oesophageal junction. Pharyngo-oesophageal junction. This pharyngo-oesophageal junction will be surrounded by some kind of muscle, which we call a cricopharyngeus muscle. This cricopharyngeus muscle will contribute to the competence of the sphincter, which is formed between the laryngopharynx and the Oesophagus. Therefore, that sphincter we call it upper oesophageal sphincter. Upper oesophageal sphincter. Now, sometimes this cricopharyngeus muscle will become incompetent, or it may compress too much on the wall, therefore leading to what we call Zenke's diverticulum, where there will be outportion of some portion of the Oesophagus around where we have the pharyngo-oesophageal sphincter, actually superiorly, and that is Zenke's diverticulum. Now, it actually will leave the neck, by piercing, entering actually what we call the mediastinum. It will enter the mediastinum, so I will show you the mediastinum pretty soon, which is found between the two lungs, in between the two lungs. Now, this is what I'm talking about. So all the way, as you can see, this is the Oesophagus, posteriorly located, and it is always collapsed if food is not going through it, behind what we call the trachea. Now remember that in the neck, these C-shaped incomplete rings of cartilage is going to be important because the Oesophagus is always collapsed, so that it doesn't, of course, during swallowing of some bolus of food, it doesn't, antagonize the entry of food into the Oesophagus. So that's why the C-shaped rings of cartilage of the trachea is incomplete posteriorly. So this, we have the pleural cavity. This area where you also find a heart is known as the mediastinum, which we'll look at its anatomy later. Now, it enters the mediastinum all the way, and it also comes into the abdomen. Now, we said that it's just about roughly 25 centimeters long. Now, what happens is that just about 1.25 centimeters long is found in the abdomen. Now, what we find is that level where it reaches is actually at the T11 vertebral level. Remember that it will pierce the diaphragm at the oesophageal hiatus, the opening over here, the oesophageal hiatus at the T10 vertebral level, and then it will actually relate to the stomach, at the cardiac part of the stomach, at the level of T11 vertebral level. So there will be another oesophageal sphincter, which we call the lower oesophageal sphincter, which will be formed between that of the stomach and the oesophagus. That's the lower esophageal sphincter. Now, the upper esophageal sphincter is quite anatomical, reinforced by the cricopharyngeus muscle, but the lower esophageal sphincter is physiological. It's a physiological sphincter, actually more or less competent compared to that of the upper esophageal sphincter, and therefore there could be that kind of reflux of gastric contents into the lower part of the esophagus, which you get to understand its application pretty soon. Now, the esophagus, just like any other components of the tubular organs of the postpharyngeal gut, is going to have 4 coats or 4 tunics, and namely we're going to have from the lumen, this is the lumen, the inner portion, from the lumen to the external parts, we are going to have what we call the mucosa. Then below that we have a submucosa. Then we have muscularis externa, and of course we have the adventitia or serosa. Now remember that the portion which is extraperitoneal outside the abdominal cavity, therefore extraperitoneal, is going to have what we call adventitia to be the outermost covering. But the lower portion, just about 1.25 centimeters portion in the abdomen, will be covered by peritoneum. So we say it is intraperitoneal. Now, this tubular organ, which is highly muscular, is going to have, it's also going to have a prominent muscularis mucosa, internal muscle layer, which is exclusively smooth muscle. And upon contraction, will bring the luminal content, that's the bolus of fluid, closer to the mucosa, so that it can actually meet the fluid of the GI tract. So that's what it's going to do, the muscularis mucosa. Now, the external muscle layer is going to have 3 layers, and these 3 layers are the inner circular and outer longitudinal layer. Now remember that these powerful muscles are going to ensure that there's sufficient peristaltic movement to propel the food, all the way throughout its length towards the stomach. Now, the inner circular one, apart from helping in formation of sphincters, will also be relevant in peristalsis that we talked about. But the outer longitudinal will be relevant in segmental contraction, so that there will be pieces of food, at various segments, to help in actually the proportion, enough proportion. Now, remember that actually we talk about these muscles as having these functions, but they work in synergy. So there's that kind of synergistic rule between the inner circular and outer longitudinal layers. Now, remember that I've made mention of this, lower part, this lower part. But remember that the esophagus can actually be divided into 3 segments. We have the upper third of it, middle third, and the lower third of it. Now, the upper third is going to have, as far as the muscle layer is concerned, it's going to have skeletal muscle. The principle is that the more you are getting to the outside part of the body, the muscle is actually skeletal. Therefore, it's voluntary. Now, the middle portion will be a mixture of skeletal and smooth muscle, because the lower portion is made up of smooth muscle. So that's one thing that you have to bear in mind. But remember that the muscularis mucosa is exclusively smooth muscle. Now, talking about this lower esophageal sphincter, which we're saying that it is, less competent, especially in children. That is why children tend to vomit a lot more often. Now, what happens is that its, stability, and for that matter, its strength will be contributed by what we call the, as it goes through the diaphragm, the right cruise of the diaphragm, the right cruise. The right cruise of the diaphragm is able to form the sling around it, contributing to its sphincteric rule. Yes, apart from this, we're also going to have, because it enters, the abdomen at an acute angle, it also helps in actually, contributing to its, sphincteric rule. Yes, apart from this, what happens is that, the walls of the abdomen, upon contraction, will increase the abdominal pressure, and it also contributes to, the sphincteric rule. But mainly, this is a physiological sphincter. And that is why if it is too incompetent, then there could be reflux of, content of the GI, of the stomach, which is, actually acidic into the lower part of the esophagus, changing the adult form, which will, of course, the epithelial lining of the esophagus is going to be stratified, squamous, non-keratinized epithelium, changing its lining into actually what we call simple columnar epithelium of the stomach. So it becomes very important that it is competent, actually. But at times, now what happens is that if there's that change, okay, we call it Barrett's esophagus, as a result of GORD, gastroesophageal reflux, disease, refluxing of the acid into this area, and it is can lead to potential cancer formation in the lower portion of the esophagus. Now remember that even apart from this, sometimes the esophageal hiatus, where the diaphragm, the esophagus piercing into the diaphragm, what happens is that yes, it can become weak, and therefore some portion of the stomach can push superiorly, okay, through the esophageal hiatus, and that is what we call hiatal hernia. So some portion can actually penetrate through it, leading to what we call hiatal hernia. But remember that, of course, we've said that esophagus, if there's no food, it is going to be in the relaxed state. But again, after seeing that we have these sphincters are just going to guard the entrance, okay, of an opening, okay, of a tubular organ. There will be sphincters which are going to help in regulating the opening and closure of such organs. But what we are going to find is that there will be constrictions. There will be some areas of the esophagus which will be highly constricted than other areas. And some of these ones, there are three main clinically important constrictions of the esophagus. And we have the one which is related to the area where it meets the cricoid, at the cricopharyngeal muscle area, where we have the pharyngoesophageal sphincter or the upper esophageal sphincter. There's one constriction over there. Remember that that's the same area where we are going to have the sphincter, the upper esophageal sphincter. There could be that constriction. Again, when we get into the thoracic area, okay, in the mediastinum, at where the bronchi, the trachea will divide into left and right bronchi, actually relating to the left more often, will be, as well as the aorta, the aorta. We call the broncho, the arch of the aorta, broncho-aortic, constriction. There will be another constriction over there, narrowing, where if there is any organ structure going to inhabit in the block the airway, block the way of the esophagus, then that is where it is likely going to be found. Again, there's a third one as it pierces through the diaphragm to enter the abdomen. There is another constriction in that regard. Remember that the the cricopharyngeal, that will be at C6 vertebral level. The broncho-aortic constriction will be at the level of T4, T5 vertebral level, which is actually related to the sternal angle of Louis. All right. Now, of course, where it pierces through, it will be at the level of T10 vertebral level. So that is one important thing that we have to actually understand as regards the esophagus. We have to know these things. Now, one thing again is that, yes, let's look at the relations that this esophagus is going to have with some organs or some structures. So of course, in the neck, it is going to relate anteriorly to what we call the trachea, apart from this, yes, the left recurrent laryngeal nerve, which will rest in the tracheoesophageal groove, yes, will also be related to it, okay, anteriorly. Then of course, yes, we also have the pericardium, the superior portion, the cervical portion of the pericardium will also be related to it. Now, at its posterior aspect, okay, now you can see that posteriorly we are going to have, in the neck as well as in the thorax, okay, you can see this is one of the vertebrae, actually cervical vertebrae. Of course, going to relate to some of these cervical vertebrae as well as the thoracic vertebrae posteriorly will be related to the bodies of these vertebrae. Apart from this, yes, it's also going to relate to what we call the thoracic duct. Remember that the thoracic duct is running with actually the aorta. So the thoracic duct as well as the the azygos vein. Azygos vein will also be there, AAT. Azygos vein will also be there, as well as the descending aorta that we mentioned, who relate to the posterior part, who be related in posterior manner to the oesophagus, because they run in a posterior fashion. So you can see that is the thoracic aorta, thoracic descending aorta. So because thoracic descending aorta will be running with actually azygos vein as well as thoracic duct, they also relate posterior to it, as well as the bodies of these vertebrae, actually, especially the thoracic vertebrae. On the lateral aspect, yes, the right lateral aspect, this is the oesophagus. So on its right side, okay, the right side will be here. Okay, the right side of the oesophagus in the thorax, yes, will of course be actually related to the pleura, okay, the pleura, which is related to it, as well as the terminal portion of the azygos vein. Mainly this will be the maintenance. And then of course the left portion of the oesophagus in the thorax, yes, will actually be related to the arch of aorta superior, that's in the neck region. But as it descends, then of course we are going to have, so mainly, yes, the arch of aorta, then of course the thoracic duct, and of course the left pleura as well. So pleura will be related both left and right side. Now in the abdomen, okay, as it enters the abdomen, anteriorly, it will be related, anteriorly, this area, okay, will be related to what we call the left, vagus vein, left vagus vein. Now, of course, posteriorly, it will be related to the right vagus vein, as well as, of course, some portion of the right cruise of, the left cruise of the diaphragm, So mainly, of course, azygos vein, the left, part, anterior part of the, right vagus nerve will be related to the left part. The left vagus nerve will be related to, the right part. So mainly, this is what we are going to find. Now, for its drainage, for its, vascular supply, it's going to come from, in the cervical region, the thyrocervical tract will give rise to the inferior thyroid artery, which will actually give some branches to supply in the neck region. And of course, the thoracic descending aorta will also give some branches to supply in the thoracic region. Then of course, when you get to the abdomen, it will be supplied by actually some branches coming from the left, gastric. So esophageal branches actually coming from the left gastric, artery will go to, supply it. Now for the drainage, importantly, what I'm interested in is the lower portion, because the lower portion has some clinical bearing. Remember that you have the left, esophageal branches of, coming from the left gastric vein, will actually drain, okay, into what we call the portal, actually to the, the portal vein, will drain ultimately into the portal vein, actually going into the liver. But remember that also again in the lower portion will be drained, okay, by what we call the, the inferior, azygos vein, actually eventually into what we call azygos vein, hemiazygos vein, actually into azygos vein, and then eventually we'll send it into what we call the superior, vena cava, actually. So what we are going to find is that, yes, it's going to be actually, inferior vena cava, actually. So it's what will happen is that, yes, if there is pressure, okay, built up in the liver, therefore resulting in retrograde of the blood which is sent to the liver through these veins, remember that they form some kind of anastomosis, okay, some kind of connection. But if there's too much pressure, then there is going to result in something backflow of the blood from the liver, resulting in the high pressure, because of course individuals who tend to drink a lot of alcohol, okay, will be suffering from eventually to cirrhosis of the liver, where the liver becomes fibrotic, resulting in that kind of backflow of blood, resulting in distension of actually veins over the lower portion of the oesophagus, okay, and that is what we call there's that kind of portointestinal anastomosis actually. But what we're going to find is that there will be that kind of build-up of pressure resulting in distension of these vessels over here, okay, and that is what we call oesophageal varices. And oesophageal varices, there's that likelihood of rupture of these vessels because of the high pressure, and which clinically you will see the patient will be vomiting or coughing blood out, and that is what we call hematemesis. So that is one important thing that we have to actually understand as regards these ones. But to sum it up, one thing we have to know about this whole thing is that yes, it's mainly going to be the pressure over here. That's what we are going to find over here. So I think we've covered enough, but let me just say this: sometimes swallowing becomes difficult. As regards the esophagus, because sometimes the muscles become hardened. Become hardened. The esophagus, phageal muscles become hardened. Now, when they become hardened, then what happens is that yes, there's that kind of inability to actually relax or contract the muscles properly, and that is dysphagia. Swallowing with difficulty. All right. So this is actually a tutorial on the esophagus. We will look at the rest of the postpharyngeal guts. Thank you very much for your audience.